When we say the word cataracts, we think nothing of it. We feel extremely comfortable with cataracts because we understand why our patients get them and when they get them. But on the flip side, when we say cataracts to our patients, many of them think that the apocalypse has begun. We wanted to review a few basics about cataracts. We'll talk a little bit about what they are and why they occur, but most importantly, we'll discuss how to talk to your patients about them. Although there are many less common types of cataracts, we want to focus in on the three main types of cataracts: nuclear, cortical, and subcapsular. In nuclear sclerotic cataracts, changes are common centrally, resulting in a more opaque yellowed lens. The lens index of refraction increases, making it an effectively stronger plus lens and causes a myopic refractive error change. Sometimes this leads to individuals having better near vision than they used to, a phenomenon referred to as second sight. Nuclear cataracts tend to get worse slowly with time, so they're usually monitored annually until they begin to create visualist symptoms for the patient. Cortical cataracts, as the name suggests, occur in the cortex of the lens. The cortex surrounds the nucleus, so the opacities are visible in the periphery of the lens. The wedge-shaped opacities can be located in the anterior, posterior, or equatorial cortex. They're often more difficult to visualize during the slit lamp examinations because of the pupillary constriction with direct light. Cortical cataracts tend to be the least visually significant during the routine visual acuity testing due to their positioning, but when the pupil dilates, such as at night or in dark illumination, they can cause large amounts of glare. According to one prospective longitudinal study, the progressive rate of pre-existing cortical opacities was 16 to 21% over 5 years. Subcapsular cataracts are opacities that are located directly adjacent to the lens capsule. They can occur at the anterior or posterior side of the lens. Posterior subcapsular cataracts, or PSC, are more common and they typically have a plaque-like appearance. They are more easily visualized during retroillumination, and because of their central or near-central location in reference to the nodal point of the eye, they tend to cause significant visual symptoms early on. Pupillary constrictions tend to magnify the symptoms, so patients often complain of trouble reading or blur with oncoming headlights. Unlike the other two main categories of cataracts, PSCs have a quicker progression rate. The progression of pre-existing PSC reaches nearly 55% after 5 years of follow-up. Educating patients about cataracts becomes a matter of not if we tell them, but when we tell them. We don't necessarily want to tell them too much too soon. However, we feel that the sooner we talk about methods to reduce the progression of cataracts, the better off we are. Cataracts most often to our patients mean old. A lot of our patients may have a vague sense of what a cataract is or does, but rarely do they understand what, in reality, we're really telling them. That is, unless we take the time to explain it. Otherwise, they just think that we're calling them old. In reality, cataracts are like wrinkles. Everybody gets them, it's just how soon and how bad. When we do decide that it's time to discuss cataracts, we should explain what stage their cataracts are, whether or not they may cause some visual changes, and what they can expect to notice in the coming years. Don't forget the basics when you explain things. Despite being familiar with the term cataract, many patients don't actually know where the lens is located in the eye. We find it extremely helpful to pull out a model of the eye, which we actually have in every exam room. Reinforce that the lens changes are part of the eye's natural process. It may be helpful to explain that the same lens changes that occurred when their near vision started to become more strained are the same lens changes that make their lens opaque now. Simply put, the lens tends to get thicker every year like a tree. Most importantly, encourage your patients to ask questions. Patients will likely ask the most questions when they're first made aware of the cataracts. Over time, they'll likely ask fewer questions and it will become old news to them. This is where we want our patients, educated and at ease. Regardless of when we decide to educate patients, it's important that we put a timeline on things. Discuss the next year with them, and maybe even the next 10 years. Educating on cataracts, whenever and however you decide to do it, is a critical and simple part of our eye health examination, and could go a long way in patient care. It paves the way for future discussion of lens changes and eventual cataract surgery, and it enforces the importance of regularly scheduled eye exams.